Hi, welcome to my channel. So listen, today we're going to talk about how you as a nurse can better care for your patients who have heart failure. Like, what are some of the interventions that you will anticipate needs to be done for this patient, and how do you take care of a heart failure patient, and what should you look out for? You have a patient that's admitted to your unit for a heart failure exacerbation. Now, what are some things that you can see objectively or subjectively that will tell you that these patients' symptoms are improving? So we're gonna get into those things in this video. Let's go. So, usually patients that have acute systolic heart failure, they'll tell you, oh, I can't lay flat. Do you ever wonder why they can't lay flat? Because when heart failure patients lay flat, they increase venous return, right? So these patients are already volume overloaded. So if you're increasing the amount of blood flow to the heart, you can put them into heart failure, because think about it. They already have problems trying to get rid of fluid that they already have. And now we're adding fluid by increasing venous return, right? This is why, for example, somebody who is hypotensive and you Trendelenburg them, what are you doing? You're increasing venous return to help improve the blood pressure. But for somebody that is a heart failure patient, this will not be a good idea. So I digress. Let's go back. So this patient tells you that I was only able to sleep sitting up. And that's because he's so volume overloaded, right? That he can't breathe if he lays less than 90 degrees. So what are some things about this particular patient that will tell you that he's getting better? He's able to sleep at 45 degrees, right? He's only sleeping with one pillow instead of 4. These are some signs that you can look for, right? That will tell you that, hey, this patient is actually getting better. And the only way you could ever know that is if you're actually paying attention to these subtle things. Another thing is the patient will tell you, oh, I couldn't even walk to the bathroom, from here to the commode at home before I would start getting short of breath. Before I was able to walk to the bathroom, and now I can't, I have to walk to the commode. And I'm still short of breath with that. Now, that same patient is able to walk from his room to the nurse's station. Improvement, right? And these are some of the things that you want to look for to help you determine, is the patient getting better, right? The other thing you want to look at is how they are overall feeling. They'll tell you, when I'm talking, I feel so short of breath, and now I can have a full conversation with you and not feel short of breath. That means that the medication is working, right? So these patients are getting better. And this is what we're looking for. We want to see their symptoms improve. And what's another thing that they want you to do with these patients every day, right? Sometimes we're like, oh, whatever, I don't feel like doing it, but it's important. And it's to monitor I's and O's. Because let's say, for example, the patient put out 2 liters, but he really took in 2 liters, whether it's, juice, tea, water, he got IV medications, and not all of those are accurately documented. It's gonna look like the patient is 2 liters negative, but he's actually net even. We want the patient to be negative. And why do we want the patient to be negative in fluid balance? Is because that's telling us that the fluid is being adequately removed. If the patient is putting out as much as he's taking in, either he's taking in too much or he's not putting out enough. So if it looks like he's not taking in that much, then that means he needs to put out more. It will increase the diuretic, right? So you got to make sure that you accurately document I's and O's. And the other thing is daily weights. This is the reason why we want to do daily weights, is because we want to see, are we removing volume? Is the patient still volume overloaded? So if the patient came in and they tell you, oh, my weight is usually 100 kilos, but they're 125 kilos. That's a lot of weight, right? So we need to monitor that weight every day to see, is it getting any better? Is the weight going down? Because if the weight is going up or it's not moving, that means that we need to increase the diuretics. These are the objective things that we need in order for us to make decisions about how to manage the patient better, right? You need to document accurate I&Os, and you need to weigh the patient every day, because that will help us to determine if the treatment that we're providing for the patient is working, right? Now, if you're in an ICU setting, for example, and you want to know, is the treatment working? This is why we put in Swan-Ganz catheters, because this will tell us what the right-sided pressures are. So if the patient had a wedge of 40, which tells me that end diastolic pressure is pretty high, then we need to diurese this patient, right? If the PA pressures are elevated, you put the patient on Milrinone. Primacor, what does that do? It dilates the pulmonary bed. So that will help with preload, right? So all of these things working together between the Lasix, the Milrinone, and the numbers, you want to see those numbers improve. That wedge, you're giving diuretics to patients on Milrinone, and that wedge is 40 and now it's 20. We're working, right? That PA systolic pressure was 50 and now we're half of that. We're getting somewhere, right? And the other thing that we do is our mixed venous. And if the mixed venous is improving, meaning it's more than 60% or more, we're getting better, right? So these are all signs and symptoms that can tell you that the patient is improving, that we don't necessarily always need the patient to tell us like you would on the floor, because you can clinically see that the patient is improving. And the last thing you look at is that CVP. Heart failure patients can sometimes have CVPs in the 30s. That's a lot of preload, right? So if you're on Milrinone, if you are diuresing, these are all things that will help preload, and that CVP should be coming down. And clinically, you can also assess the patient. Are they able to talk in full sentences, right? Because if you can't breathe, you can't talk. Right? And if you tell me, oh, I can't breathe, but you're able to talk to me in full sentences, you might not be able to breathe, but not enough where you're not able to talk to me. Once you can't talk to me, you really can't breathe, because it takes breath to talk, right? So, Swan-Ganz catheter again, daily weights, and strict I&Os, clinical symptoms, the patient able to walk around the unit. The patient can't walk around the unit when they came in and they still can't, then the diuretics are not working, right? Maybe that patient needs a drip, a Lasix drip or a Bumex drip. Maybe that patient needs a metolazone, Zeroxylin, right? To help potentiate the effects of the diuretics. Maybe that's what that patient needs. So all of these things are important. And if the patient fails that, then their renal function is getting worse, their volume overloaded, and they're having metabolic derangements. Maybe their potassium's going up and their phos because of their renal failure, and they're overall just not doing well. It might even be anosarchic, just swelling everywhere, not only in the belly, but everywhere. Then it might be time to consider dialysis. So again, as the bedside nurse in these situations, like, you're the eyes and ears of the patient, because clinicians depend on you to notify us what's happening with the patient. So this way we know what to do and can intervene early. So when you understand these signs and symptoms, and you understand certain things about what to expect, then it makes our life easier, and it also improves the outcomes for the patient, right? Once you take all these things into consideration, then you will be able to better care for the patient. I also want to note that when you're giving Lasix, you also want to monitor for renal failure and electrolyte abnormalities, magnesium hypomagnesia, and hypokalemia. Those are the two common things when you're given Lasix. And if the patient's potassium is low, for example, let's say they're on 40 milligrams of Lasix twice a day and their potassium comes back at 2.8, you should notify the doctor and hold that Lasix until the potassium is repleted, because hypokalemia can induce tachyarrhythmias, okay? So always make sure that if the patient has a lot of urine output and they've been persistently hypokalemic, you notify the attending, you notify the clinician, so this way they can hold off on a diuretic until the electrolytes are replaced, because electrolyte derangements can induce tachyarrhythmias, including VTAC. Last thing is, if you have a patient that's on spironolactone or aldactone, spirolactone, right? or aldactone, these patients are at increased risk for hyperkalemia because it's an aldosterone antagonist. So it blocks the action of aldosterone. And what does aldosterone do? Aldosterone is responsible for potassium excretion and sodium reabsorption. So if you're not reabsorbing sodium, you're at high risk for hyponatremia. And if you're not excreting potassium, you are at high risk for hyperkalemia. Okay, so sometimes these patients are usually on spironolactone and they're on Lasix sometimes to help counteract the two. But they both work well together given that there's no renal failure, right? And that concludes my video. So please take all these things into consideration when you're caring for your patients, and make sure that you stay on top, know what you're doing, ask questions if you don't know, and make sure, last but not least, they gotta be on that low sodium diet, right? Because remember, with sodium comes water. So if they're on these high sodium diets, that comes along, sodium brings water, so next thing you know, the patient will be volume overloaded. So that's why we have them on like a 2-gram sodium diet, because we really want to monitor the amount of sodium we're giving them, because we will just counteract the effects of what we're doing, which makes no sense. So it's like getting a milkshake right after you've ran on the treadmill. It's like, okay, you're defeating the whole purpose. Same thing, right? Anyway, thank you for watching my video. I hope that you have already subscribed. If you haven't already, follow me on TikTok if you have, or Instagram, because I have lots of videos there, also lots of information for new grad nurses, new grad nurse practitioners, seasoned nurses, and the information that I have on my page is valuable. At least I think so, but you could be the judge when you go to my page, okay? All right, thank you for watching, and don't forget to subscribe. Bye.